Good morning, Dr. Lurie. It's a great pleasure to have you join us today. You're one of the leading figures in the compression world, and I'm so excited that you will present this lecture to all of us. As we know, you began your career in 1980, serving as a faculty member at the Urals Medical University in Russia, and then subsequently at the University of California and the University of Hawaii. You're currently an associate vice president of the Jobst Vascular Institute and an adjunct research professor in the Department of Vascular Surgery at the University of Michigan in Ann Arbor. Your main interests, as we know, are venous and lymphatic diseases, venous physiology, and clinical imaging. You serve as director of the American Board of Venous and Lymphatic Medicine, director of the Vein Center Accreditation Board of the Intersocietal Accreditation Commission, and member of the Medicare Evidence Development and Coverage Advisory Committee of the CMS. Wow, what a list of duties. You're past president of the American Venous Forum and the American Venous Forum Foundation, and you're also a member of numerous committees for the Society of Vascular Surgery. You're an honorary member of the European Venous Forum and other elite European societies. You've been a principal investigator on 18 multi-center clinical trials, published more than 200 articles, invited commentaries, and 17 book chapters. We know you're an accomplished speaker and you've given 200 talks, both nationally and internationally. Again, Fedor, it's a real pleasure to have you join us this morning. We look forward to your presentation.
Thank you, Dr. Caprini. It's really a privilege to be invited to talk at your virtual meeting, and I really appreciate it. So what is the value of interface pressure measurement? I have no conflict of interest related to this topic. Well, the answer to this question is very simple. The interface pressure is the dose of compression, and applying compression without knowing the dose is the same as giving any medication without knowing the dose. The practice of not knowing the dose of compression while we're applying this has significantly damaged the evidence base for compression therapy. For C2 disease, as you can see, there's no reliable evidence supporting specific dose because it wasn't measured. The same is true for C3 disease and for lymphedema. Venous ulcers are an exception, and bandages have strong evidence support, as well as high pressure stockings. But we should ask what kind of bandages and what kind of stockings. The most recent ACCP guidelines perhaps is the best example of how much damage can be done by applying unknown dose of compression. The recommendation against using compression in patients with DVT was based on the results of a single trial, SOX trial, as we know it. In that trial, compression stockings labeled as having 30 to 40 millimeters mercury pressure were compared to so-called placebo stockings. Please note that the pressure was not measured in any of the patients, and the label of 30 to 40 millimeters mercury applies to a single point, B1, when stockings were tested on a dummy, not on a real patient's leg. The tested pressure of placebo stockings were 5 millimeters mercury at the ankle and 8 millimeters mercury in the upper calf. In fact, this placebo was anti-graduated low-pressure stockings. Published data demonstrate that low-pressure stockings, as well as anti-graduated stockings, provide similar and sometimes a better effect compared to standard compression. So the correct conclusion of the SOX trial should be that low-pressure anti-graduated stockings prevent post-thrombotic syndrome at a similar rate compared to 30 to 40 millimeters mercury graduated compression stockings. However, we don't really know because we didn't measure the pressure and we don't know how much pressure was applied to an individual patient legs in each trial. Even bandage system have stretch control, require substantial expertise to how apply this pressure. You can see in this picture, Dr. Caprini has his leg bandaged by Hugo Parch. No question that both of them are experts, but we will be seeing how much of the other people's expertise can help with applying the right compression dose. In this study, wound care nurses with more than 5 years experience applying correct bandages pressure only in 30% of the patient, 33, 1/3. And in the majority of patients, they receive not graduated compression and not even anti-graduated compression, pardon, but totally random along the leg. Ready-to-use compression stockings are not much better than bandages. 1 of every 10 stockings applied pressure that is different from how it's labeled. And the distribution of pressure along the limb is also varied substantially. The mixed venous and arterial ulcers present a particular challenge. The interface pressure should be lower than perfusion pressure. But how do you know if you don't measure? Even more, the actual pressure inside the limb is always higher than on the surface. If 18 millimeters mercury pressure is applied to the skin, the pressure in subcutaneous tissue is somewhere between 30 and 40 millimeters mercury. The pressure in the muscular compartment is even higher, and 40 millimeters mercury bandage produces 70 millimeters mercury inside the muscular compartment. Fortunately, there is available devices that can measure compression stockings. You can see the PicoPress device here. Some of them, like a JUZA device, are really practical, and you can slide this device under the stockings on the bandage to the B point, measure the pressure, and as you withdraw this device, you can see the change in the pressure, making sure that it's applied in a graduated compression manner. So, although the optimal dose compression for individual patients is still need to be defined, I think the old standards of practice is no longer acceptable. Despite practitioners believe that they are doing good jobs, the majority of patients today continue to receive inappropriate compression. I'll call it double-blind therapy, when neither physicians nor patients know which dose of compression should be or should apply actually the leg. And I don't strongly believe actually that this practice should not continue any longer. Thank you very much for your attention, and I'll address any questions that you may have.
Thank you very much, Fedor. Very, very nice lecture. And this is really important. And if the doctors and healthcare personnel will understand this, but the public has to understand it too. And that is that there isn't a drug that you take that doesn't have a dose. And what you're trying to teach us is that we have to have a dose for this very important compression for the legs. Now, it's fine for those people who have a little aching or tenderness and they need a little bit of support, then they can wear a stocking. But what about, Fedor, people that really need stockings, that have severe edema, let's say, that type of thing? What do you recommend that that person does in order to get the right stocking?
Well, that's a really difficult question. It's an excellent question. So I would suggest a couple of solutions. You mentioned stockings. Actually, people with a substantial swelling, especially those who has swelling that changes over time, will be much better off with some devices that can adjust the pressure over time. Velcro devices, for example, there are several of them right now on the market. So when the swelling goes down, especially after night sleep or elevation of the leg, a patient may want to adjust this stockings, this device, so the pressure will be applied appropriately. When they feel a discomfort because the swelling increases despite the compression, they may actually lose it a little bit to be more comfortable, and so they wear them. So this is one of these. Those devices, though, are expensive and not always covered by insurance. So the stockings is another solution, of course. And fortunately, all the studies that I referred to show that higher pressure stockings have less variance in terms of pressure delivery compared to low pressure, and especially over-the-counter stockings, because those are not really designed for the longitudinal wear for several months. So I think it's important to have as high pressure as patient can tolerate with the stockings, with the prescription stockings with a good quality.
Thank you, Fedor. Now, if the patient goes to their family doctor and the doctor looks at them and says, you know, you have some leg swelling, we need to give you some stockings, gives them a prescription, then what should the patient do? Who should the patient seek out in order to get the best available product?
I would suggest, based on my own experience, if I would get a prescription, I will go to a place, most likely orthopedic supply store, because they have more, usually they have more choices available. And I will ask them if they carry several brands of the stockings. And if they don't, I will go to another place because I really need to look at those. And I will choose with the major brands, Medi, Juzo, Sigvaris, Jobst, those four. And I will look at the different materials that they have, and I will try with my hands and see which one I think is better for me, feels more comfortable. And I also will look, of course, on the color and other things that look at the stockings that I will really be wearing them and not hesitant to wear them in public. So I will choose this pair of stockings and will try them. Now, I would also do a second pair of stockings. I will purchase a second pair of stockings with a slightly different material and see if those going to be over time more comfortable. Now, somebody will say this is quite expensive. We have 2 pairs of stockings, but remember that I will need those stockings for years. So if I spend some money at front and find a brand and a material of the stockings that I comfortably can use over time, I will save actually money by purchasing the same pair of stockings when they are needed again. Now, if I may address another issue here that relates to the measurements. So usually we recommend people to get a new pair of stockings every 6 months. But that is not a universal true, because if you have a measuring device, if your physician office or any place, even the supply store may have those devices, measuring devices, you can go there and check whether your pressure is still enough or not. And again, just pure on my own experience, I can say that some pairs of stockings actually last much longer than 6 months. I have a pair that I wear for more than a year that still has the pressure. At the same time, some stockings don't last even 3 months, and the pressure drops substantially, and I don't feel it. But when I check it, I can see that instead of 30 millimeters of mercury, I have 18. So I have to change this.
That's very interesting. Now, the multiplicity of factors and facets that you've discussed, it seems to me that the only way an individual, a person, just the average patient can really take advantage of all of that is to go to an expert fitter. And so now they go to this expert fitter, and the expert fitter talks to them a little bit and gives them a quote. And they say, oh my goodness, that's too high. I'm going to go home, see if I can go to Amazon.com or on the internet and to the stocking place and buy stockings on the internet. Now, how do you feel about that?
Well, and it may work for some people, but not for the majority. What they will end up doing is one of two scenarios. Either they're going to at some point stop wearing stockings and the disease is going to progress more, or they're going to try one pair and then going to try another pair and then going to try a third pair, and then it will go back to that expert feeder and got a real pair, wasting time and money on this device. You know, this is very interesting, because when it comes to the medical therapy, a physician writes a prescription and you go to the pharmacy and the pharmacist gives you a medication. You don't go to Amazon and ask whether I can replace this medication with some. Well, some people do, and it's okay. I mean, you probably can try different things, but that is a standard. And those medications go through the very rigorous process of approval by FDA, and their manufacturing is standard, and their dose is known. Well, with the stockings, it's a challenge. So when you see in the retail store 25 different stockings, neither one of them have a standard manufacturing, nor they have a known compression or any other qualities, durability that have those medical stockings that are available only by prescription.
Thank you very much. Now, I want to have you also address a very, very important problem that we're faced with, because there are challenges from what's written in the guidelines to what I would call clinical realities. And I'd like you to explain to the audience, especially the patients, what is this story about not wearing stockings when you get a blood clot in your legs? Don't you come into the, you know, it's in the guidelines that they don't recommend that based on that trial that you showed. But patients come into the office and they have pain, swelling, tenderness, aching, tiredness in their legs. How do you deal with that if you're not supposed to use a stocking? Could you explain that whole thing to us?
It's another excellent question. So the actual guideline language is very interesting, because what they say is they do not recommend compression stockings to prevent deep vein thrombosis. And then they do a comment. And the comment says, well, but you still should use compression stockings to address patients' symptoms. There are several aspects of this. The first one is, yeah, we should use compression stocking to reduce symptoms. There's studies well done documenting that early use of compression reduces swelling, reduces pain and discomfort in patients with deep vein thrombosis. The studies that show that ambulation is equally effective that rest, the bed rest, or maybe more effective, all of those studies use compression stockings. So when we say that the patient should walk instead of laying down in the bed, we should not forget that the patient should walk with the stockings on. That's another aspect that's very important. And finally, I think the other important aspect of false recommendation that I call these guidelines is that the study that they use, SOX trial, started compression stockings not earlier than 2 weeks after the onset of deep vein thrombosis, after the onset of clinical manifestations. And most of patients gets much later. So they miss the entire most important time of acute disease. So when they show that there is no difference in the symptoms of post-thrombotic syndrome between placebo, so-called placebo, I talk about this, not really a placebo, and the real stockings, they're missing the most important time, which is the actually during the acute event. So I strongly believe that all patients with acute DVT should have compression stockings from the time when they see a physician.
Thank you, Fedor. As I'm sitting here listening to you discussing this, I'm thinking in my own mind, we've both had the extremely good fortune to be with the father of compression, Professor Hugo Parsch, who has really set the stage and is the world expert and has taught us all of these things over the years. And as you were talking about your various points that are important in this, I can think back to all the studies that Hugo Parsch did to prove exactly what you're saying. And it's very, very important. And I'd like to really impress again on the audience. You've got to know your history, because if you don't, then you're going to have to start all over again. So this has been a wonderful discussion this morning, and I'm so thankful that you've come on and presented this work. And we look forward, Fedor. This won't be the last time we'll see you. So thank you very much again for being with us today.
Thank you, Dr. Caprini. I really appreciate you giving me this access to the audience, and I hope that some of the messages went through. I really hope so.
Oh, I'm sure they did. Thank you very much.